The Self-Care Learning and Discovery Series is back, and it's bigger and bolder than ever. This is the premier self-care event of the year, bringing together self-care enthusiasts of all backgrounds and disciplines from around the world. The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. We also know that self-care means different things to different people. What does self-care mean to you? You'll have ample opportunity to reflect on this question during the Discovery Series, with more than 20 interactive virtual sessions organized by self-care experts worldwide. The Discovery Series will elevate cutting-edge research, programming, and advocacy insights across a wide variety of self-care topics, and we encourage you to attend as many sessions as possible, especially on topics that may be new to you. The Self-Care Learning and Discovery Series, a core activity of the Self-Care Trailblazer Group, is organized by the White Ribbon Alliance in partnership with co-sponsor organizations and esteemed steering committee members. We also want to thank all our session organizers and presenters who have voluntarily dedicated their time to curate this event with us. We are pleased to share that every session will offer live, simultaneous interpretation in French, Spanish, and English. To access the interpretation, simply navigate to your meeting controls located at the bottom of your screen. Click on the globe icon labeled Interpretation and select the language you'd like to hear. Joining from your phone, tap on the ellipses to find the interpretation feature and then select your language. Please note, you can switch languages at any time throughout the presentation. The session is now about to begin. Don't forget, whether you're working to influence policies or programs, advance universal health coverage, or improve your own self-care, we hope that you will take the learnings from today's discussion and apply it to your own work. To that end, we invite you to continue the conversation and take action with us by becoming a member of the Self-Care Trailblazer Group. So get curious, jump in, and share your ideas and insights with us. We look forward to advancing self-care together.
Hello, everyone, and welcome to today's session titled Pills by Post, Pills by Prescription, and Telemedical-Supported Community Health Workers, African Self-Care Model for Abortion and Post-Abortion Care. In case you are just joining, as the video mentioned, this session has interpretation in French and Spanish, so you can listen to your preferred interpretation checking by clicking on the world icon in Zoom. Next slide. So during this session, we will be using Zoom Pool and Zoom Whiteboard interactive tools and also the Zoom chat. So we encourage you to ask questions. Please add any questions that you have for our speakers in the chat. We'll be reviewing the Q&A towards the end of the session. And the chat is available also on PC and mobile, so please feel free to add any questions. So we are joining today from all around the world. I'm Veronica Fernandez, and I'm the operations manager at Women on Web, and I'm joining from Madrid in Spain. I will be the moderator of today's session. And today as speakers, we have Ellie Mas-de-Connor, that is the head of marketing at Mary Stop in Ghana, and is based in Accra. Victoria Satchwell, who is the Executive Director of Abortion Support South Africa, and she's joining from Johannesburg. Welcome. And Dr. C. Akumawa, who is joining from Bamenda, where she's the Executive Director of Easy Health Cameroon. Next slide. We will start today's session to learning a bit more about who is joining us today. So we invite you to use this Zoom pool that will appear in your screen now. So you will see some questions on your screen asking where are you based and your level of familiarity with today's topic, that is self-managed abortion and telemedicine abortion and post-abortion care. Please click the option that applies to you. We will have a couple of minutes to do this. Nice, Isabel. Okay, so we have the results. Not sure if you're seeing them on your screen, but you have people from all over the world, almost a lot of from Europe and um, Central Asia, but also from South Asia, Sub-Saharan Africa. And we have a majority of people who are already working in service delivery, research, and policy on this topic. Thank you. Thank you very much for your participation. Really nice to see that we have a diverse group. Please, next slide. Let's start with a small introduction on self-care models for abortion and post-abortion care. Self-managed abortion refers to a spectrum of practices in which individuals conduct some or all elements related to the abortion process with no or little involvement of healthcare systems. Typically, self-managed coexists with interactions with trained healthcare workers or with healthcare facilities. The way in which abortion is accessed will depend on the values and preference of the women, girl, or a pregnant person, but very important also available resources in the national or local context. A plurality of service delivery approaches supporting self-managed abortion can coexist in any given context. Telemedicine on abortion and post-abortion care is a way to facilitate self-managed abortion by providing access remotely to some elements or the totality of the elements needed to have a safe abortion. This being information, access to quality medicines, and to support, medical support if needed. It's a model to deliver an abortion service in which distance is a critical factor, in which we use communication technologies for the exchange of information or to provide clinical support. The COVID pandemic compelled a rapid shift to build virtual services. This means not just building the infrastructure and creating platforms for patients and providers to communicate, but also adjusting the skills, the knowledge, and the attitudes of providers and patients. Many people had limited or no experience with telemedicine prior the pandemic and are now more comfortable with it. Telemedicine on abortion and post-abortion care has shown to be highly acceptable for users. There is a strong demand, of course, where access to abortion is limited, as well as in locations where in-person care services are available. It allows patients to be seen sooner, particularly important for time-sensitive procedure like abortion, and address barrier to access like distance or stigma, providing more privacy. While telemedicine at first might look like a simplification of in-person care, in which it can be partially or totally remotely, the logistic requires to provide these services are quite complex and comply a series of components that need to work out separately and coordinated to be successful. Let's look at some of those components. First, we have information. So first you need to market the service, how to get users to find your services. Then you need to provide medical information to them or information on how to access the commodities, for example. Then, of course, you need human resources. You need providers, maybe to prescribe the medications, community health workers, doctors, midwives to be in contact with the users, or different staff to run the whole system. You might also require a system for patient intake to get and store the information needed, the evaluation, and the communication. And this might be a phone, a digital platform that you have developed, or even the community health workers themselves. Of course, you need payments to sustain the service. And for that, you need payment methods that can be accessible in your context. And of course, you need the commodities. Commodities is key, but also we also need the medication, but a system to deliver these commodities to the users in a fast and safely manner. And we also need a way to follow up on cases. Each context will provide different challenges around these components, as well as different opportunities in which you can adapt the different elements. For that, we have the different examples of today's speakers. Let's see how telemedicine and post-abortion, in abortion and post-abortion care has taking shape on the African continent, and the models our speakers have built to solve these challenges in their context. First, we have Elimas, who will tell us about the delivery of telemedicine abortion in Ghana that Mary Stop has implemented. Elimas, if you want to start, please, next slide.
Thank you, Veronica. So in 2021, MSI Ghana, through the advent of COVID, we actually worked towards more health innovations to reach out to more women by piloting a telemedicine model for medical abortion. And the process is quite simple. It starts with a call from a client to us in a contact center. A few screening questions are asked and a booking is done. Then a health provider later on will call this client, take the client through further eligibility questions, consultations, seek a consent, and request for payment. And payment is done through, we call it in Ghana mobile money, but it's also M-Pesa elsewhere in Africa. Then the package is it's per the preference of the client. We work on the package and the dispatch picks it up and delivers to the client. At the end, within 7 days, we actually call. We call the client back again as a follow-up to check and see whether the process was complete, an opportunity for feedback, and that is how our process ends there. It was a pilot study, and within the period of the pilot, we actually saw over 800. We met the need of about over 800 women out there. And 97% of these women reported that they've been successful in their termination through our method. We started from a low of seeing 3 women seeking access for telemedicine medical abortion to seeing a high of granting access of about 104 during the pilot period. But I must emphasize and clarify that as I speak to you, currently, we are granting or providing access to safe medical abortion through telemedicine for about 180 women every month on month. That's how it's. So in terms of clinical clinical incidents that we've seen are the MA failure rates are acceptable. It's close to what we normally see in our standing clinics as well. And if they are MA failures, per our procedure, we do a referral to our nearby clinic and partner clinics for an NVA to be done. I'll end, Veronique, by mentioning that the telemedicine medical abortion on telemedicine has actually met a huge gap in the society, in the community for women, and the satisfaction rate has been high. We've seen 84% of women actually recommending that they will actually come back for the service. And then we've seen higher net promoter scores of about 83% ready to recommend our services, the telemedicine service, to other friends. The other option that that really struck us was the fact that 1 out of 3 women who actually took up the service said they had no other option if telemedicine for abortion wasn't there. I'll leave you with a simple client feedback that we have here about a lady who actually reached out to us and successfully took up the service. So that's the Ghana story. Over to you, Veronica. Thank you.
Thank you so much, Elimas, for sharing. Next, Dr. C, we would love to hear more about how Easy Health has implemented their model in Cameroon. Please.
Thank you very much, Veronica. I'm very thrilled to be here. And just for context, Cameroon, the English-speaking parts of Cameroon is have been going through
I think we're having some small connection issues. Dr. C, we cannot hear you at the moment. Well, we can do, otherwise, maybe we can go to Victoria from Abortion Support South Africa that can explain her model first, and hopefully in the meantime, we can get connection back from Dr. C. Please, Victoria, if you would like to share more about your model.
Thanks, Veronica. So in South Africa, we don't deliver through courier or, like what Dr. Z is going to say in Cameroon, through community health worker, but with prescriptions. And a prescription is a registered. And I think it's important to emphasize that because telemedicine is an operational challenge, the size of the organization that you're coming from is also going to make a difference, and the capacity that that organization has. So in South Africa, the way that the service works is that women visit our website and they complete an online consultation. A partner doctor then reviews their case and assesses if abortion at home is safe for them, and then prescribes abortion pills, mifepristone and misoprostol. The patient can then collect their medicines from a pharmacy nearby, and they'll be directed to an abortion-friendly pharmacy that we vetted. The doctor provides instructions on how to safely manage the abortion at home, and the patients can get in touch with the doctor with any questions or concerns. And then there's, of course, follow-up afterwards to see that the abortion was successful. So our service is actually an adaptation of the Women on Web service. So we used the Women on Web patient management infrastructure, as well as their protocols, but we adapted that based on the South African law and policy. So we were looking at abortion law, as well as digital health policy, and health information law, and pharmacy law, and then adapting the Women on Web to fit within South Africa. During COVID, there was a policy change on prescribing that made telemedical abortion possible. Whereas before COVID, patients needed to see a patient at least once face-to-face before they could prescribe. And then after COVID, during COVID, that changed, and the doctor didn't need to have that face-to-face contact before they would prescribe, opening the door for telemedical abortion. South Africa has very liberal abortion laws, but we do not have telemedical abortion guidelines. And there is some, I think, reticence or nervousness among providers to actually provide telemedical abortion because there isn't that explicit guideline. And they are... So I think that a lot of providers are waiting for that before they'll start providing, whereas there's nothing in policy right now that prohibits that. And in fact, government is very interested in providing themselves. Importantly, we're not an abortion provider. Abortion Support is not an abortion provider, but we are a digital front for the doctors and the clinics. So we connect the patients and the providers. In South Africa, for an abortion to be legal, it must take place from a designated clinic. So that's a clinic that the government
Seems that Victoria also
That's-
got a,
Oh,
you got a bit
that's-
frozen. So if you
Oh.
could get it from no, but it's working now. So
Okay,
yes,
sorry about
yeah, starting this slide again.
So then patient information gets sent to the patient management system from our website, and the doctor can then interact with the patient through the patient management system. So the doctor assesses the case and communicates through the patient with the patient via email, but again through the patient management system, which is very important because you want all of your information to be in one place, because you don't want to be missing any important information either coming to the patient or from the patient. And then once the doctors assess that the case is eligible, no contraindications, then a prescription is sent via email to the pharmacy. Again, it must come from the doctor here. That's according to South African law. So the patient can't print out an e-prescription. It needs to come through the patient management system to the pharmacy. The patient then collects her medicines at the pharmacy and pays at the pharmacy. I think it's also important to notice that a lot of the work that we do is actually based on social media. So we're making women aware that the service is available, that it's legal, that it's safe through social media, and then through our social media accounts, they come to our website. So that is how we've been providing in South Africa since around Feb. And at the moment, we're seeing around 150 consultations per month. Thanks very much, Veronica.
Wow, that's great. Thank you so much, Victoria. I don't know if we have Dr. C back in the room.
Yes, I'm here.
Oh,
Can you hear me?
perfect. Yeah, we can hear you loud and clear.
Okay.
Please share a bit your model.
Okay, I'm just going to dive into it. So I was going to give a background on the context we have in Cameroon. So Cameroon has been experiencing, the English-speaking parts of Cameroon has been experiencing a protracted crisis for over 6 years now. And because of this, we have medical personnel that have migrated or displaced themselves from these rural communities for their own safety. So this has caused a serious shortage in medical personnel. Apart from languages. So this means every little community has its own language, which sometimes serves as a barrier, especially when it comes to communication. Also, in Cameroon, abortion is illegal, but it is legal in various cases, where there is a case of incest, where there is a case of rape, or if the woman's life is in danger. So having all these in mind, we at Easy Health, we therefore sought to have a solution that uses basic digital technologies, mobile phone, so that we could have messaging.
Seems we're having some small connection issues.
Sarah, do you think it would be helpful if I gave a little bit of an intro to the Cameroonian model?
Yeah, of course. Yeah.
I've been I've
collaboration with
yeah. So the interesting thing about this service is that the community health worker connects the patient to doctors through telephone, through mobile phone. So the community health workers are in very hard to reach communities, often where there are language barriers and where patients or women may not have access to mobile phones or to money to load their mobile phones to talk to doctors. So the community health workers are working in those areas already. And then Z went in and trained them to start providing post-abortion care. And so when a woman is in need of care, she'll go and talk to her community health worker, and the community health workers are trained on self-managed abortion and post-abortion care. They also have commodities with them. But what's been very important and interesting is that because there's so much stigma in many of these communities, the role of the doctor is, of course, to provide medical advice, but also to provide trust in the service. And so the patients really do like that there is the doctor on the other end they can get in touch with at any point through their community health worker. The medicines are coming from, so all of the community health workers are working from a hospital or a clinic in that area. And that's where they are then getting their drug supply from. And women can either get their meds directly from the community health worker or be referred to a hospital where they can get their medicines. So it's a referral model as well. And let's see, is there anything else that I want to mention? Sorry, Z, I hope I'm doing you justice. I think that's it, Vero.
Thank you so much, Victoria, for introducing a bit the service from Dr. C in Cameroon. It's amazing how this model has been adapted to increase access, adapted to such a diverse and different context. So next thing that we will do, we want to do an interactive activity, and for that we are going to use Zoom whiteboard that will appear in your screen. So we want you to think like a telemedicine model designer. And for that, we invite you to contribute with your ideas, as I mentioned in this whiteboard that will appear now. So let's think together about the payment component of a telemedicine model, especially the barriers that women might face paying for services, and why might they unwilling or unable to pay for digital service like abortion or post-abortion care. So you will see the whiteboard. Let me show how you can put a sticky note. Let's use sticky notes for this. So under the symbol of the T, you see the sticky note. So you just need to click. You can select the color of the sticky note that you want to put, and then you click directly on the whiteboard, and then you already have the chance to write your ideas regarding what barriers might women face to pay for a telemedicine service. Let's see what it's coming. Privacy. No credit card, so they can make online payments. Yeah, especially some of these services with remote attention. Don't have enough money, of course. Doesn't want the payment to be traced on their name. Exactly. That can be, of course, due to stigma, but also due to being in restrictive context. Don't want the husband to know, and they might have sharing accounts. Exactly. Scared to be traced by governments. Very young, not being able to afford. Fear of paying due to scammers. That's a good point. Some of these new telemedical services, and when you get access remotely, you mistrust when you are not seeing the person live. So yeah, you might be scared to be a scam. Not access to their own funds or only share funds. Yes, we see a very similar. Please also know that you can, if you struggle with whiteboard in the activities that we are doing at any point, you can also share in the chat. We'll be taking your options in the chat, and we'll take them to the whiteboard ourselves. So don't worry if you can use the sticky notes. Thank you very much. Exactly. It's some of them are repeated, like minors, like not having the means, and of course privacy. Yes. Let me check the chat. Yes, please leave your notes on the chat as well. Thank you so much for your participation. Oh, let's wait for a couple more. Yeah, no bank account. Exactly. Like only being able to pay in cash. Or not familiar with online payment literacy. Same, only used to pay in cash. Thank you so much for your participation. Exactly. That's mostly the barriers of payment that are facing these services by women. So we'll wrap up here. Thank you for your ideas. We want to hear a little bit more about our speakers and their model, how they do with these different challenges. So first I will go to you, Elements. When we think about telemedical abortion, an important design component is getting the commodities to the women, so getting the pills to the user. Can you talk us through how you solve these and what challenges have you encountered in Ghana?
All right, Veronica. When it comes to telemedicine, as you rightly said, it's about the delivery, pill by post. You need to get the right courier partner to work with. We face a lot of challenges with having anti-choice courier partners, for instance, who end up keeping the packages and not delivering them on time. And what we ended up doing was for us to get our own internal courier for the deliveries, especially in the capital, Accra. We've been able to partner with new courier companies, but having learned our lessons, we actually took them through more trainings, especially on safeguarding, to ensure, or even do VCAT as well for our courier delivery team. And yes, that has actually helped, because stigma is out there, and we want to let them know, and also to be sure that we are actually working with the right people. But our advice that if you are starting telemedicine, especially when it's bill by post, be sure about the courier partner, so that it's not an anti-choice courier partner that you have. We also try as much as possible, we ensure that the names packages, we don't put names on our packages. They are just numbers, client numbers that we put on it. So it's so anonymous to provide extra safeguarding and privacy and confidentiality for our clients who reach out for telemedicine. So that's what I'll say about the courier, Veronica.
Thank you so much, Elimas. So, Victoria, on the other hand, in Abortion Support South Africa, you don't carry it. So you have women collecting the medicines directly at the pharmacies with a prescription from the doctor. So why did you choose pharmacies as a way to distribute the abortion commodities for the service? And how has this worked out so far?
This actually is a cost saving mechanism. So in South Africa, unfortunately, the postal service is not reliable. So that wasn't an option for us. And courier is incredibly expensive here, particularly medical courier. And we do in fact have a very good network of pharmacies that do stock misoprostol, not so much mifepristone, but so we wanted to make use of that and use the prescriptions. Also because we believe that abortion pills should be available the same way that other medicines are. We want the pills to be in the pharmacies, but unfortunately, this has actually been very challenging for us. We've seen a lot of conscientious objection from the pharmacists. So pharmacists are denying access, which we actually have in South Africa policy that explicitly says that they can't do that, but we still see that happening, unfortunately. And so we've sort of trying to do quite a big campaign around trying to get pharmacists to understand the context that they're involved in, and also the law and policy and what their role is in self-care.
Thank you so much, Victoria. Dr. C, I don't know if you're back in the model that you presented. So you get the medicines directly from the community health workers or from a hospital that women are referred to. Can you tell us, walk us through how you selected and trained the community health workers? Because we know that not everyone, as our other speakers are sharing, working on health wants to be part of abortion and post-abortion care provision. Can you share a bit more on that?
Yes, definitely. So yes, women can get medications from either their community health workers or from the local partner hospitals in their areas. But we've also found that drugstores as well have been an area that they would love to get access, they would love to get their medications from. And so it's a new area that we're exploring in our model. And with regards to training and selection of the hospitals and the community health workers, before we began the work, that's over a year ago, we actually spoke to all hospital directors in our location, in our project location. And from the discussions that we had with them, we were able to know who was going to be able to work with us and who was not going to be able to work with us. Because even in the legal context, most medical personnel will not accept to work in this area. So after doing that and having like a short list, we organized VCA trainings, that's values clarification and attitude transformation trainings for health personnel plus their directors and for community health workers. Because after these trainings, only then will you know who you are able to work with. And this is very important because the attitude of the health facility and that of the health personnel in the health facility will directly affect the access to care, because not every woman will want to go to a place where they may be stigmatized or where the service that is being provided is not right based. So that is how we've been able to go about that.
Thank you so much for sharing. So interesting how stigma becomes an issue in these components as well. I would like to talk a bit about pricing and payment now, like following up on the interactive activity that we have done. So payment mechanism, the way that a person pay for the service, let's be cash or credit card or any other online payment, and pricing as well are elements of the model design that have a clear effect on access. If you could, each one of you, very briefly explain how your services are priced and how women deliver payment, and how this can affect the access. If you want to start, Elima?
Right. In Ghana, with MSI Ghana, the telemedicine cost for early medical abortion, it's $40 US, and it's comprehensive. It includes delivery cost as well, low cost delivery. It's one of the key elements that we really consider. Consultations. The medical package is one of the cost drivers, and the time of the provider as well. And in terms of payment, we only use the M-Pesa platform or the mobile money platform to take payments from our clients who reach us to us for service.
Thank you so much. Victoria, how do you handle payments with Abortion Support South Africa?
So in the beginning, we were running a donation model where we were asking women to make a donation of around 150 Rand for the service. But we found that there just isn't a lot of online payment literacy, and we don't, unfortunately, have mobile money in South Africa. So very quickly we realized that wasn't going to work. And so right now we do not take a donation or a charge for the service, and women pay for their medicines in the pharmacy. We are looking at starting to provide a delivery service through an online pharmacy, and that will be quite a nice payment, a price discrimination opportunity for us, where we say, you know, if you aren't able to make an online payment, you can go to a pharmacy and pay for your medicines here, or you can use the delivery service. But then, of course, we do need to take payment because they're not going to be going to the pharmacy. And then that will also probably be a slightly higher socioeconomic demographic, someone with a bit more money if they do actually have a credit card. And then we feel more comfortable taking a donation in addition to the cost of the medicines.
Thank you. C, how do you handle payments with Easy Health?
Okay, with Easy Health, unfortunately, we are unable to regulate any payments because the medication, first of all, there is one medication that is being used for post-abortion care, which is misoprostol, and it's readily available. It's only available because it's used for other reasons. So these hospitals are the suppliers of the misoprostol. So what we were able to do at the beginning of the project is that we only connected them to suppliers. So the idea about connecting them with suppliers was so that they can preferably get them at discounted prices, which should affect the prices that they are giving it at and the cost of the post-abortion service. So unfortunately for now, we're unable to, but we're hoping that if we can, in the future, be able to provide this medication, then it may affect the prices that that they are being offered at. But for now, we're unable to regulate any prices. However, most of the payments that are being done to the health facilities are cash payments. So.
Thank you so much. And regarding access, it's not only access to the payment methods and access to the to the money, but also making this accessible. There is people who also has other issues like literacy to these methods. And any of you could share about how do you handle and facilitate access and knowledge, regarding payment, but yeah.
I think access is such an important concept, and so many people, I think, maybe don't take an expansive enough view on access. But because all of us work directly with women, part of our job is to understand how they experience the service. And this, improving access is an iterative process. You're always looking, how is this person experiencing it? What problem am I solving today? You're going to get new problems every day, and you're going to have to try and solve them. And I think that sometimes people, I was talking to someone working in the pharmaceutical industry, and they said, oh, but it's just 200 Rand more. And I thought, wow, this person just really doesn't get it. You have to put yourself in the shoes of the person who's using the service and understand that any additional task, any additional website they have to go to, any payment mechanism, anything they need to read or sign, or that is a barrier to access. So anything that you're adding to your service is a barrier to access, and it's iterative. You're going to be redesigning as you go to improve access.
Thank you. Elimas, do you in Meritstep have any other mechanisms to improve access?
Yes, I agree to Victoria's points around being human-centered in providing access. So for our pilots, when the whole idea of access actually came in, we were being iterative. But we have several examples that I want to cite and how we brought out, like we've actually implemented innovations in improving access. But I want to just talk about two which were profound on me. When we started, we get clients calling from outside Accra, and most of these clients are semi-illiterates, and they have a language barrier. So it created a watershed whereby we cannot provide services and consultations for these clients because consultations must be in English and instruction leaflets for the medications are also in English. So what did we do? We actually had a video translated on self-managed termination into Twi, which is the most spoken language in Ghana. And we shared this video after consultation with these clients to help guide them further to understand how to take the combi pack medications and other medications that we share. So another point was where we had a client who it's blind, and this client actually has to sign a consent form. So when we got to know that, yes, consent form, we need to bring some innovation. So we introduced a thumbprint whereby we guided our delivery, our courier person to protect the privacy of their clients when he gets there and ensure and guide her to do the tampering. So that's two key examples, profound examples that I can give on access on how medical abortion through telemedicine in Ghana has actually achieved great strides by giving more women access to safe abortion services.
Great examples on how to lower barriers. Thank you so much for sharing. So let's go back to another interactive activities. Let's go back to our whiteboard. And this time, let's try to think together about the solutions to the problem that we previously exposed. So we first share about the barriers that we think that the women might face to make a payment. So now let's think together, how can we overcome these barriers to payment? Let's think about if you're trying to develop a system in your context, how would you address these barriers and solve these problems in your context? So let's do the same thing. In the whiteboard, you can select sticky notes. If you're not familiar with a sticky note, it's totally fine. You just share your comments on the chat and we will include them in the whiteboard. So please share with us how do you think we could address this? Let me check. We have a couple of minutes. Solidarity models and donation-based models, discount and waivers on some aspects of the services, exactly to help for those users who do not have the means to pay for services. We need to establish some kind of subsidy, as other comment included, abortion funds that can help us pay for the services for users. Well, but we can sustain our services. Ooh, payments to an account with a neutral name, so that it's not obvious that you are paying for an abortion service, or like Mike's Food Shop was the example. Yeah, or a more generic, that's a great idea, like with a more generic name for an organization that yeah, it's not clear that it's offering abortion services or post-abortion care services. Get funders to pay for the commodities, yes, instead of having to make users to pay for those. Private insurance or national insurance to cover for the cost. And what about the different models of payments? That sometimes it can be an issue when people don't have credit cards or other digital payment platforms. What other solutions can you think for those barriers to pay? Use of mobile money for those settings who allow that. Send cash in the post, that could be an option. Some kind of cash payment system, so that the person does not need to have this more difficult or bank account or a mobile app for payments. Yes, of course, it's different solutions address different barriers. And of course, what solution can be used in what context, as we are seeing now with our speakers, but that might not work in another context, or we have to adapt the solution differently. Deposits in person, when you can, of course, in the case of, for example, the model in Cameroon that has community health worker, it might allow for some in-person payment. Oh, in the case of abortion care, miso alone is a cheaper option. For example, it's true for those who need to cover their own supplies. An abortion with mifepristone and misoprostol, mifepristone tend to be a much more expensive drug. So only an abortion with misoprostol is definitely a cheaper option. So it will lower the cost of the service that we are providing. Have a drop-off point for cash payment. A great idea. Certificate of deposits from bank. Thank you so much for your participation. It's great, all the ideas that you're sharing. Let's go back to the discussion with our speakers and all the different aspects of the model. So one of the components that we have mentioned is communications. Communication with women, it's a key element of any telemedical service. First, we need to know, the women need to know that our service exists. And as Victoria was explaining, we might use social media for that, or website, or we use traditional marketing or healthcare provider referrals. But then we need to receive the information from the patient about the pregnancy, their health, but also then communicate instructions on how to take the medicines, do a follow-up, but also information on logistics, on the package, for example, the tracking number, or where to collect the medicine. So all these communication elements might be solved by using a tech-heavy solution or multiple systems, or simply a telephone and a pen and a paper. I would like to learn more briefly if any of you could describe how the communication telemedical element of your service, but also please mention a bit on how these solutions can influence the cost of the service that you are providing. So first, Elma, if you want to explain more.
All right. communication is everything when it comes to telemedicine, and there's cost involved. In Ghana, we use telephony, the latest range of telephony. We are even upgrading it to remote now from standalone. And we also use chats. And we use a lot of integrated systems, which costs a lot. And in addition, we also have huge costs on our human resource from the midwife. Currently, she handles an average of about 20 consultations a day. We are even thinking of bringing a locum, which is an additional cost as well for quality. So yes, all of this built in makes it a bit expensive though, but it's possible when you think more about access.
Thank you so much. Victoria, how do you handle the element of communications in Abortion Support South Africa?
So the difference between our service and what Marie Stopes in Ghana is providing is that we are asynchronous, whereas they're providing face-to-face. And that's why LMS was saying, you know, that really pushes up the cost, because then you've got a midwife providing face-to-face communication all day. And so we're email-based. So that means that a woman can send us an email, and the doctor, you know, will then respond within usually within 12 hours they aim for. But usually it's much sooner than that. So it's email-based, which of course is a problem in many cases, because it's only a very particular demographic that has email. So we would really like to move towards WhatsApp, but as LMS mentioned, all of these tech solutions require a lot of expertise and money. But for us, the next step is getting our service to WhatsApp, where most women are actually wanting to be communicating.
Nice, thank you so much. And see, how do you coordinate this communication element in Easy Health?
Okay, for us, it's usually through the community health worker. So the community health worker makes a simple phone call or sends a message via messaging. And we do this in order to reduce the cost from the client, because if we're not going through the community health worker, then the client will need to bear that cost. And in most cases, the client either does not have the phone or does not have the airtime to make that call through. And apart from this, the language as well, because the community health worker usually serves as a translator. I think I mentioned earlier that there's so many different languages, and you will be working in an area where they are unable to speak English. So the community health worker makes that call through, and in so doing also translates whatever the client is, or whatever worry the client has. So we use basic technology, mobile phone call and messaging.
Thank you. Another very important aspect of model design is reading all these, the various guidelines, laws, and policies that regulate abortion care, but also regulate prescribing, digital healthcare, privacy, and health information, and ensuring compliance to those. Very few countries have abortion guidelines that directly address self-managed abortion or telemedicine. Eleman, can you tell us a bit more about the incredible work that Maria Stop has done in Ghana to developing telemedicine guidelines? Like, how did you do it?
All right. It's one thing that in Ghana we are so proud of, collaborating with the government. And WHO guidelines have made it easier for us. So when we started this pilot, we worked with the government, specifically the Ghana Health Service, the Family Health Division. So we had reps from the Family Health Division who were co-principal investigators of this pilot. And what that's inured into is a shift in the abortion guidelines, whereby telemedicine, it's now part of the guidelines for abortion provision as an access as well. So for women who want for a specific barrier and need and want termination through telemedicine, they are now backed by the new guidelines that we've been able to influence through collaborations with government to ensure that we have telemedicine as a medical abortion provision option for women as well. And this has opened the door for other partners such as IPPF and others in Ghana to also start looking at telemedicine for abortion as well.
Thank you, Alima. And see, you operate, as you explain, in Cameroon in a setting where abortion is restricted in most cases. Can you talk us through how to address this?
Yes, definitely. So abortion is really restricted in Cameroon, and however, there are some areas where it is possible. Unfortunately, even in these areas where it is legal, like I said, in rape, the case of rape, incest, and when the woman's life is at risk, you still have health personnel who are not willing to offer the service, even in these cases. So that is where the value clarifications and attitude transformation trainings come in, because you are helping the medical personnel rethink their profession and really say that this is what they're supposed to be doing. Also, in cases of rape in Cameroon, if there's any pregnancy under the age of 16, that is rape. There is no consent under 16. So these are some areas of the law where you are able to, let me say, look at and be able to provide better services when need be. So that is how we've been able to navigate this issue. And also, even when you're talking about the law, honestly, the bigger barrier is the stigma. The bigger barrier is the stigma, not even the law. So you have somebody who is more afraid of what people will think of them rather than what the law will do to them. So that is why it is essential that our health personnel, our community health workers, that they are able to receive and communicate with clients in a way that does not make them feel any kind of way, or does not make them feel like they should not be getting this service done. And the first way is about actually trying to make sure that the service is available wherever they are. So yeah, thank you. I hope this answers the question.
Yes. Stigma being a bigger barrier than the law in some cases. Yeah.
Yes.
Victoria, so you had an interesting challenge because, as you explained, you're using the existing Women on Web model and infrastructure, and you have adapted it, this international service, to the South African regulatory framework. Can you tell us about this process?
Yeah, so we had to read a lot of the laws and the policies to try and understand how we would fit in. And I would say that it was also interesting that it was quite difficult to get legal advice. There were very few lawyers who were interested in working with us. And so we did a lot of the policy analysis and legal analysis ourselves. And it was also interesting to understand all of the different places that this service touches, because it was the agency that regulates doctors. They have their own guidelines on how digital healthcare can be provided that are very specific. And so we had to integrate those and change the service to ensure that it was working. Also, pharmacy law is actually very complicated, and e-prescribing, which is what our doctors are doing. It's different depending on what schedule it is. In South Africa, there's laws around wet ink prescriptions, so meaning that the signature actually needs to be signed by the doctor. It can't be an image, or it needs to go through something called IES, which is a very high-tech electronic way of signing documents. We also had to look at data privacy, and that, of course, is something that comes up. People are very concerned about when using something like WhatsApp. And we've sort of trying to find workarounds around using WhatsApp to provide services. So what was very interesting was just how extensive you kind of had to look in many different places to find all of those different laws. And we're very interested in trying to get all of those elements together into one document that we can start using as a de facto telemedical guideline. And I think that it's important to just start building those guidelines. If you don't have them in your country, start building them, and bringing in different stakeholders to add to them.
Thank you so much, Victoria. So I would like to invite all our participants today to start dropping their questions for our speakers in the chat. Anything that you would like, you can address it directly to one of our speakers, or do a general question so that they answer how they have adapted this in their different contexts. So please feel free to add your questions. I'm going to keep on asking Elimas, like in Ghana, what kind of numbers do you see? I think that Mary Stops has clinics. Do you see a decreasing number in your clinics because of the telemedicine service? If you could tell us more about that.
Yeah, yes. We must all agree that self-care is the future of healthcare, especially for safe abortion services. And in Ghana, we've not seen any drop in terms of the visits to our clinics. In fact, 1% of only 1% of our telemedicine, if telemedicine wasn't available. And we've seen a lot of higher women having gone through consultation, opting for medical abortion, show that they have absolute processing the option of medical abortion through. And we serve several young.
Elima, we are having some issues with your sound at the moment. Like it gets a bit cut, and I think it's a very interesting question to learn more about the different demographics of people who are actually accessing these telemedical services. So I will get back to you. Hopefully in a bit it gets resolved. In the meantime, Victoria, so you mentioned that some pharmacists do not provide the medicines to women that they have been prescribed. So they go there with a doctor's prescriptions. Like, how are you dealing with this problem?
So a lot of the work that we've been doing is identifying friendly pharmacists. So we have a very large map with around 300 pharmacists that we can say are willing to help us. And that's based on every single time a prescription is sent by the doctor to the pharmacist, we call, we ask if they've got misoprostol in stock. Most of our prescriptions are in fact misoprostol because it is so much cheaper in South Africa. And we ask them if they're willing to dispense for abortion. And we tell them that, in fact, there is policy that says that they are not, as pharmacists, allowed to refuse. And so we have this list that we're building. And what was also important was that we're trying to build we were trying to contact pharmacies around transport hubs, because of course, we don't want pharmacies in the middle of nowhere. We want it to be where women can actually get to. But we've also been working with the Pharmacy Council and different agencies that work with pharmacy, trying to get them involved. And we've been, it's been quite interesting seeing that really pharmacists don't know very much about abortion. Some of them are genuinely concerned about safety. So they're saying, but what about follow-up? Isn't this woman going to bleed out? But a lot of the denial of service is stigma. And so we're working with these different pharmacy agencies to put together a guideline for dispensing for pharmacy and medical abortion guideline. But eventually, our initial approach is always going to be education, working with pharmacists. But at some point, we will need to say, you need to stick to the law. You need to stick to policy. Eventually, we will have to take a bit more of a hardline approach.
Thank you so much, Victoria. So, you mentioned drugstore and nurses providing formal care. It seems like stakeholders behave differently than expected, and sometimes this can be helpful for women. How do you bring these kind of players into the fold?
Okay, thank you. So I'll just dive briefly into how we got into working with drugstores. And this was because in one of the hospitals where we were working at, the director was changed. And so you have a director who was okay with the service, being changed to a director who is no longer comfortable with the service. And now because of this, the health personnel that was trained in this facility, we realized that she also had a local drugstore where she was doing some side business. And because the facility is no longer, I would term it safe for the service, especially for clients. We therefore had to work with her because of the relationship that we'd already built with her, knowing that this is somebody we can work with. We therefore worked with her such that community health workers were able to now refer clients to her local drugstore rather than to the hospital. Because as I said earlier, the attitude of the health facility in general will affect the access that these women have. And we do not want a situation like that. So we are working based on trust. We're working based on past experience with the health personnel we're talking about, and we're working based on the fact that they are also able to get the medication and provide the post-abortion service to the clients.
Thank you, C. Not sure if we have Elimas back. Now, yes, I will get back to his questions regarding clinic birth. Oh, Elimas, you're there.
Hi.
Yeah, so
Yes.
let's go back to the question. Yeah.
Okay. So I was just trying to say that for telemedicine, telemedicine has not affected uptake or visits to our standing clinics, and it rather enabled higher access, whereby women have more responsibility and they track better, whereby after consultations, we've seen about more than 85% on average since we started the pilots taking up service. And it's only one agreed. Can we? But in terms of service, it's an.
Yeah, unfortunately, we are missing you again. The sound is coming on and off. So, but yeah. Victoria, did you want to say something?
I wanted to say maybe Elimas would write his answer in the chat for us because I really want to know this one.
Yes, Elimas, please feel free to give us a brief of the answer in the chat so we will read it. So, Victoria, now that we were talking, like you started Abortion Support South Africa recently, and it's a small organization. Can you tell us about the process of setting up a service as a new organization and setting up already a telemedical service?
Mm-hmm. I think it was so interesting talking to Elimas about the service that they've set up, and both of us just agreeing it's a massive operational task. And I think a lot of people working in abortion are maybe not that familiar with setting up business processes and operations. You know, a lot of us come from medical backgrounds or activist backgrounds or research or policy backgrounds. And this, you know, telemedicine really is operational and it's business processes. And so I, you know, as a very small organization, we were in a very different position than someone like Murray Stopes, who has a lot of the organizational backing. They've got a lot of their business processes, their HR, their payments, their accounting, whereas we were setting that all up in parallel with setting up the service. We were very lucky because we are very closely partnered with Women on Web. So we were able to piggyback off a lot of their services and take a lot of their learnings, not just from a telemedical perspective, but also from an organizational perspective. It was very good to speak to Elimas about this, just understanding how tough it is. It really is a tough thing to do. We found it so, and it's a grind. You're constantly reiterating, changing, seeing how is this going to work in my context. And I would also say that the role of stigma in doing this work is profound. And particularly when you're setting up business processes and needing to work with suppliers. And then finding that someone doesn't want to work with you. So for example, a printer saying, no, we won't. And that can be on a daily basis that you're receiving that kind of feedback. Or if it's talking to the pharmacist every day and they're not playing ball, and that really can wear you down. So it's a long haul setting up a service. It takes a lot of resilience. And the way that I think about it is that every struggle that we have as an organization is a struggle that women don't have to have in accessing abortion.
Very nice. Thank you. I would like to read one of the questions that has come in the chat in French that is directed to you, C. It says that in Cameroon, you mentioned abortion is prohibited except for certain exceptional cases. What medications are available to community health workers in Cameroon?
Oh, okay. Yes, it is restricted, but you have medications that are available. In fact, the one medication that is available is misoprostol. Usually, mifepristone and misoprostol is being used, but we only use misoprostol not only because it's cheap, but because it is also available. It is worth noting that misoprostol is used in other cases, like if a woman has a postpartum hemorrhage, they have to use misoprostol. So because of this, it is possible to find misoprostol in registered pharmacies and even in the government structure that supplies medications to all other hospitals. So the medication that is available to the community health workers is the misoprostol.
Thank you. I'm going to read because Elimas provided the answer to the question about the numbers that he sees, comparing in clinic, because Mary Stop, of course, has clinics and telemedicine. So he mentioned self-care of self-managed abortion is the future. Currently, we see around 180 complete consultations a month. Women have huge confidence in the service, as more than 85% of women will opt to complete determination on telemedicine after medical consultation over the phone. We have not seen a drop in the number going to the clinics. In fact, only 1% of telemedicine clients agreed to go to the clinic if telemedicine was not available. We have come to see that women who go to the clinics are very different demographic than our telemedicine patients. I think this is a bit connected with what you explained before, that for some of them it's the only option. It's not, yeah. Let me get back to other questions. In the chat, I see another question. How do you ensure that women understand side effects, which are normal, of the medical abortion, and what is a serious complication? Often women present themselves to a facility and undergo an MBA when one could have waited for the procedure to be completed through medical abortion. Would any one of you like to answer this question, maybe Victoria, that you provide everything remotely?
I think you should answer this question, Vera. You're also an operations manager.
Yeah, I can later on complete on this. Of course, Women on Web does all of this remotely too and provide all of this information by email too. I mean, if you would like to start, then I can also mention a bit more about Women on Web.
Sure. I think that providing information upfront about possible complications is incredibly important. And also that the information design is very important. And I think that Safe to Choose does this very well. If you go and look at their infographics, they provide, I think it's 3 situations where, in this case, you will need to go to a hospital. So that information is always provided up front. And of course, at any point when we receive, I'm experiencing some bad smelling discharge, or I'm in so much pain, or, we have a list of particular triggers for go to an emergency room. And you are completely right. In many cases, you know, we always tell women abortion is a process, and this is also included in all of our information that we give. Abortion's a process. It can take some time, and we actually do mention also that we don't recommend having an ultrasound immediately after the abortion, because not all healthcare providers know that you don't then need to go and do a surgical. So what we find is, if you give women information that's accurate and that is well presented, then they are actually going to be good stewards of their health.
Thank you so much, Victoria. I mean, I have not much to add to that. We're going to follow same guidelines. We provide information on what is expected and what is not normal. Like at the same time, that information is provided and clearly explained so that they can differentiate what is part of the process and what is a sign of complication. See, I would like to ask you, what are the challenges you face, if any, by working with community health workers? I envision that hard to coordinate in general.
Yes, yes, it is sometimes. The issues we face working with community health workers is actually the issue of compensation. I think that's been our biggest issue because after we had our trainings and all, what we were able to offer them is like an airtime package so that they're able to make those calls and they do not bear that cost. And because they do not see financially the gain, the extra gain that they are getting from doing this service, it's sometimes difficult to get through to them. And we're hoping that there will be a time where we are able to compensate them fairly for the work that they're doing. And also, like even when we talk about providing the misoprostol to them so that we can reduce the cost on the client, it's also going to be a challenge because if we do this right now, they are benefiting off providing these medications. So we find ourselves in some kind of a dilemma, but we are constantly talking with them, and we're hoping that in the near future we can have the ability to provide some kind of compensation for the work that they are doing. Because right now, honestly, for the efforts that they are putting in, it's probably not enough. So I think that's the major challenge that we have working with them. That's the major one.
Thank you so much. Yeah, totally understandable. I would like to go back to Elimas, because you end up your sentences mentioning how the demographics are different between in-person and telemedicine care. And actually, I'm a bit curious about how are these group different, if you could put some examples.
All right, Veronica, listening client younger.
Oh.
And most of them are students, and yes, they are busy. They have busy schedules, and they tend to go to the pharmacy for self-managed abortion. So, but they need a guide. The pharmacists mostly don't have the training and information to give them the information, that guide, and they actually don't really assure continuum of care. So that's why they reach out to our telemedicine service. Yes, you find slightly older, maybe between out of school, who mostly opting for NVA, moving to the centers more, but you find more MA being mostly for those who are younger, below 25 down to 18.
Thank you so much, Halima. I'm going to go back to the chat. One of the questions is a chat, and I would like to invite anyone else who wants to ask something, as we will be soon finishing today's session. So please feel free to ask your last questions in the chat. Somebody mentioned, could you share any experiences of offering telemedicine abortion service to adolescents and minors in your respective settings? Any specific challenges and opportunities that you have encountered with this specific population? Mm-hmm. Anyone would like to mention something?
I can take that. I think.
Okay.
Oh, Z, you go, please.
Oh, okay. I just wanted to dive in because we had a specific challenge with not a specific experience with an adolescent. As I think I said that in Cameroon, under 16, it is a case of rape. And what we have realized is that most of these cases who are minors under 16 or cases of rape or incest, they are being brought by either their mothers or their fathers because of the so-called disgrace that will probably ensue if everybody knows that your child was 15 and is pregnant, or your child was this and is pregnant. So you see that most of the cases, I think most of the cases we've seen, they have come with a parent, which was helpful for us because then you have a legal guardian who is able to provide some kind of consent. Because again, we are working in communities where you will not want to get into problems with the entire community, and you're going to be hoisted out of that community, generally speaking. So when you have that backing of a parent or a guardian coming in this kind of situation, it feels better for us as well, and the process will definitely goes smoothly. I can understand if there are more difficulties if you just have a 15-year-old or a younger child coming to a facility or coming to a community health worker by themselves, but those are rare. So I just wanted to share this experience of us seeing these younger children coming with a guardian.
Thank you. Victoria, would you like to answer?
Yeah. So we're very clear that we provide services to people of all ages, and we think it's very important because particularly young people find it difficult to access in-clinic services because many services are not designed to cater for young people. We ask for date of birth in our consultation so we can immediately see how old someone is, and we pick up if they're under 16 years old. And in those cases, additional communication and support is sent to them. We ask them if they are able to speak to an adult or a friend or family member for support. And we explain that it can be more comfortable if you are able to speak to someone to provide just additional support. In some cases, they are able to do that. They have a friend or someone who can help them. In some cases, they aren't. And when they aren't, then we just really make sure that we follow up very well, both from a payment side, as making sure that they actually get the medicines, but also just keeping in constant contact with younger women.
Thank you so much, Victoria. So if there are no more questions, I think we are gonna finish our session of today here. So if you would like to share your thoughts on the session, please find an evaluation form that we'll be sharing in the chat. We would love to hear your thoughts on the session. And I would like to thank our speakers of today, and on behalf of Women on Web, Abortion Support South Africa, Easy Health Cameroon, Mary Stop Ghana, and of course the Self-Care Learning and Discovery Series. Thank you all for your time and your active participation in this session. We hope that you take something from this session and that you get started on setting up telemedical abortion services in your context. Please we'll be very grateful if you share your thoughts on the session in the feedback form. Thank you, Victoria. See Elima. It has been great to speak to you.
Thanks, Vero.
Thank you so much, everyone.
Thanks for having us.
Thanks. Bye, everyone.
Bye, everyone. Thank you.